Hi everyone, how are you all doing? I welcome you all to this recall marathon, and this is something that we tend to pride upon. You know the importance of an early recall. These days, we have a lot of emphasis on the pattern of the exam and its associated uh, importance, not only for this exam but for all the future exams. So I hope you guys are attending this recall. I know you guys must be tired and you will be exhausted, but this is very important. If you spend these 4-5 hours doing this recall session, then it definitely helps you a lot in understanding the pattern of the exam and how things are and what can be done, what can we start improving from tomorrow. So you can probably take a break half day tomorrow. And from what my understanding of this exam, from whatever feedbacks I have got, is this is a moderately difficult paper. So don't beat yourself down if you see that you have probably attempted less or there are more number of questions you feel that you have made wrong. It is not going to be a very high scoring exam because it was a difficult paper from what I saw. And yes, so I am here to discuss the part of anesthesia, but as it is always with anesthesia, anesthesia is always one of the easiest subjects in our entrance. So this time also we got very easy. We got two questions which are from anesthesia. These are the two direct questions. There were few questions that could have been called in anesthesia, but it is mostly some part where there was a element of diagnosis in medicine, and then there was a nasociliary nerve block that was a part of what ENT teaches you. So I'm not going to touch that. I'm only going to discuss the two direct questions that came in anesthesia, and both of them came from what we normally teach in the class. We emphasize that it is one of the most important and yet most easily done topics. First is from CPR, and anybody who has attended my class, I have told them that CPR is a 20-minute topic from which you get one sure shot question in the exam, and that is exactly what has happened. And of that also we got a recall. Where this is a question that was asked 3 years back in INICET only. That time it was AIIMS, and the question was on quality of CPR. They gave 4 statements: chest compression 100 to 120 per minute, ventilation 20 to 25 per minute, adequate chest recoil, and depth 5 to 6 centimeter for an adult. And then the options where all options are correct, A and C are correct, B is correct, A, C, D are correct. So this question is from one of the most important tables that we discuss in CPR, that is do's and don'ts of high quality CPR. If you remember this image, I spent a good amount of time on explaining the do's and don'ts of high quality CPR. 5 do's are rate 100 to 120. That means not less than 100, not more than 120. Depth at least 2 inches. 2 inches around 5 centimeters. Not less than 2 inches, not more than 2.4 inches. So 5 to 6 centimeters is the ideal depth of compression. Allow full recoil after each compression. One of the very important things which we fail to do while we are doing CPR is that we don't allow adequate chest recoil. We keep on leaning on the patient, and that is why the intrathoracic pressure never really gets negative, because when the chest recoils, there is a negative intrathoracic pressure that sucks the blood from periphery, which doesn't happen, and eventually the ejection fraction keeps on decreasing. So you do not have to lean on the chest between the compressions. Minimize pauses in the compression, because whenever your compression is paused, that time there is global ischemia, because there is no blood flow to any part of the body, and that is what decreases the prognosis of a cardiac arrest victim, because both the heart as well as the brain, they require a constant supply of blood for them to be able to survive. So you don't stop compression for more than 10 seconds. Do not interrupt compressions for more than 10 seconds. adequate ventilation, that is for every 2 breaths, for every 30 compression, you give 2 breaths, each breath lasting for 1 second. That is the adequate ventilation, that is 30:2. It should not be like you provide excessive ventilation. That means you keep on increasing the frequency as well as the force of ventilation. Again, ventilation increases the intrathoracic pressure. If you keep on over ventilating the patient, then again increased intrathoracic pressure will decrease the venous return and it will adversely affect the outcome. So the option here with ventilation 22 to 25 per minute is obviously the wrong option. And so the correct answer to this question is option A, C and D are correct. Option A, C and D are correct. This is something that we discuss every time in our class, and I have always maintained the fact that if you want to read one topic that you are 100% sure that you will get a question in the exam, then that is CPR. All right. So this was one question which was very expected. Another question was also on the similar lines. Again, this is not a direct repeat, but it is a similar question was asked few years back. And it is a question where a patient on pneumonia is on ventilator with a respiratory rate of 14, maintained on SpO2 100% with FiO2 90%. pH is 7.33, PEEP is 12, PCO2 is 48, PO2 is 110. Which of the following steps to be done? Increase PEEP to 14, decrease FiO2, decrease respiratory rate, increase tidal volume. Now for understanding this question, we have to first understand the clinical situation. Clinical situation is pneumonia, that is a lung condition because of which the patient has been put on ventilator. So I am sure that the patient would have either respiratory distress because of which the patient was breathing very fast and not maintaining saturation, or basically pneumonia has caused hypoxemia, which we want to correct by intubation and mechanical ventilation. So our idea is to achieve physiology, right? And then we rely on the respiratory and ABG parameters to do this. We rely on respiratory and ABG parameters, right? So on the ventilator, from the information that is shown to us is that there is a respiratory rate of 14 per minute. And some people have also told that tidal volume of 320 ml. Now this is something of a gray zone for me. This is something of a gray zone because most of the recalls, they have not told me about tidal volume, but two students actually told me that there was a tidal volume of 320 ml. Okay, now Sachin is telling me it is 420 ml. Okay, so tidal volume of 420 ml. Very good. Is it there for sure? Just a second. हाँ, जसप्रीत नहीं चल रही है, क्यों, क्या हुआ? नहीं, मैं बात कर रहा हूँ बच्चों से, क्यों? नहीं 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 चल रहा है. हाँ. Okay, tidal volume of 420 ml and 70. Very good. Are very good. If it is a 70, very good. So now we have two more things. Okay, we have the weight of the patient, that is 70 kg. And we have the tidal volume, which is 420 ml. Perfect. Now this question is making much more sense. Now this question is making much more sense. Very good. Wonderful. Thank you so much, guys. Now weight was 50 kg. Okay, let's say that the weight was 50 kg. Anyway, let's keep it 50, or it's very unlikely that they will give 50 kg. Kush, are you sure it is 50 kgs? Because usually whenever they talk about a individual, the weight is always the weight that they say is always 60 to 70 kg. And considering that they have given a tidal volume of 420 ml, then it looks like, yes, it looks like, yeah. Okay, let's for a minute consider both. It's okay, that is not a problem with us. Okay. So you have a tidal volume of 420 ml. Okay. On a FiO2. What is FiO2? What is the fraction of inspired gases that contain oxygen? These are your respiratory parameters with a PEEP of 12 centimeters of water. PEEP of 12 centimeters of water. This is your respiratory parameter, isn't it? And let's look at the ABG. pH is 7.33. PCO2 is 48 and PO2 is 110. Now for our reference, I am going to write the normal values of ABG in front of it. pH normal is 7.35 to 7.45. PCO2 is 35 to 45. And PO2 is 80 to 100. 80 to 100. Right? Now what should be done? So from normal, let's see what is the deviation. There is very slight acidosis. pH is fallen little bit, very slight acidosis. You can't even call it a frank acidosis. There is very marginally high PCO2. 45 is normal. 48 is just marginally high, and 110 is the PO2. 110 is the PO2 on a FiO2 of 90%. Now this 90% FiO2 is very high. Now considering that most of the time we talk about a lung protective ventilation in a patient of pneumonia who has been put on ventilator, we are considering that this must be a ARDS type of picture where we go by low tidal volume of 6 to 8 ml per kg. We go with high PEEP, and the basic PEEP that we keep is 5, and you can go higher. You go by the concept of a high respiratory rate, and you can maintain a permissive hypercapnia. You can allow the PCO2 to raise so that you don't have to increase the tidal volume to maintain the parameters, right? Now here what is happening is at an FiO2 of 90%, we are getting a PO2 of 110. Our requirement is basically to achieve this 80. 110 is more than we need. And rest of the parameters are not deranged so much. So there is no point in increasing PEEP anymore. Why? Because PEEP causes alveolar recruitment. And PEEP as a strategy is used when you have high FiO2 with low PO2. When you have high requirements of oxygen and still low PO2, then you increase the PEEP. So increasing PEEP is out. You are already maintaining a very good PO2. ठीक? Decreasing respiratory rate. Decreasing the respiratory rate is going to increase the PCO2, causing CO2 retention, and it will decrease the pH, causing respiratory acidosis. So decreasing respiratory rate is gone. Increase in tidal volume. Now whenever your patient is having problems with oxygenation is when you increase the tidal volume to achieve adequate oxygenation. Here already if you consider a 70 kg man, then you are giving a very good tidal volume of 420 ml. 70 into 6 ml per kg is 420 ml, which lies in the parameter of your lung protective ventilation, and you have adequate PO2. So I would not want to increase the tidal volume of this patient. But yes, what I can do is I can now try to decrease the FiO2 of this patient, because 110 is more than what I need. I need around 80. If I can start decreasing the FiO2 slowly by 10% every 1 or 2 hours and then do an ABG and take a call, maybe I can put him somewhere around 50% FiO2 with a PaO2 of around 80 to 85 to prevent the oxygen toxicity. To prevent oxygen toxicity. Okay. So with the paradigm of a lung protective ventilation, I would want to maintain a very adequate level of PaO2 by decreasing the FiO2 in a patient that has been put on the ventilator for pneumonia. And with pneumonia, we consider most probably the reason for ventilation would be an ARDS type of picture. So we try to use a ARDS lung protective strategy. So this was again a very technical question, but most of the students told me that even if they were not able to understand the real meaning behind the question, they could very easily do a question like this by ruling out the options. They knew that if PCO2 is 48, there is no point of decreasing the respiratory rate because it will again increase the PaO2. There was no point in increasing the PEEP because they knew oxygenation is good. The only confusion was decreasing FiO2 versus increasing tidal volume. Now, a lot of students were fixated on the idea that 7.33 is acidosis, 48 is higher. So I would want to wash out. But for wash out, a better strategy is to increase the respiratory rate rather than to increase the tidal volume. Tidal volume will basically cause improved oxygenation by more alveolar recruitment and expansion of the alveoli. It can have little effect on the PCO2 and pH, but again, PCO2 is a feature of, it is a function of respiratory rate. And I would not want to go into the increased tidal volume and that associated with barotrauma. Rather, at this point of time, 7.33 is marginally lower than normal, which is okay with me. 48 is marginally high than normal, again, which is okay with me. But 110 of PaO2 is not acceptable. That can increase the risk of oxygen toxicity. So I will decrease the FiO2 to make it somewhere around 50%, right? So these are the two very, very predictable, easy clinical questions asked in anesthesia. If you feel anything else has been asked, then you can write on the chat box. I would be very happy to answer you this. But as far as I have found from what has happened, it's okay, bache. It's okay. Look at it as learning, Ashish. It's okay. You might have marked all the questions in radiology correct. It's okay. At the end of the day, what matters is that whether we are reaching somewhere around 140 to 150. Hai na? That is what matters. Nothing else matters. So don't worry if you get few questions wrong here and there. Everybody makes mistakes. Idea is to just make sure that you are at a level which gets you a seat. That's it. Our idea is not to do PhD in any subject. So can you guys recall any other question of anesthesia or this was it? Perfect. So I am going to hang up this session so that now you can move on to the next part of the discussion. I wish you very, very best. You have a nice day and I'm always available for doubts. You can WhatsApp me on my number. You can contact me on my Instagram page, my Facebook page. I'm always available to clarify any doubts that you have. Yes, nasociliary nerve block will be discussed by ENT. I usually don't teach it, so I'm not discussing it. Individual nerve blocks of head and neck is something that they teach you for the surgeries that they do. So nasociliary block will be taught to you by, discussed by ENT. All right. Right. Perfect. So I'll see you guys around. All the very best. Good night.